Okay, we made it. You made it. End of the day. Last speaker on upper GI abstracts, Dr. John Lee, a local boy, is here, who is professor of medicine and the associate director of the H.H. Chow Digestive Disease Center at UCI and an expert on all things upper GI. John, thank you for coming.
Thank you, Garrett, for your kind invitation. So I'm going to present some bite-sized abstracts, no disclosures. So an upper GI treatment, upper GI bleeding treatment. This study looked at hemospray versus standard therapy. 4 randomized studies. It was a meta-analysis. And kind of the take-home was that hemospray works. So it worked particularly well for malignancy bleeding, and that kind of makes sense because we don't really have a good treatment for malignancy bleeding. But even in non-malignancy bleeding, it worked pretty well, and there was no difference in any of the specific outcomes. So I think that might be a worthwhile and easy treatment in patients who have upper GI bleeding. This is an interesting abstract that looked at endoscopic band ligation versus APC for treatment of GAVE. And I've actually never done banding, but this abstract shows that it actually worked pretty well. So eradication rate was higher, recurrent bleeding rate was lower, transfusion requirement was lower, and adverse events was a little bit higher. They didn't really go into what the adverse events were, but it seems like a pretty easy, simple, quick treatment for patients who have GAVE because APCing these patients, often it's pretty laborious. This abstract looked at cryoballoon ablation. So Raman mentioned cryoballoon. I've never done this in the stomach, but I would think it would be kind of painful to do cryoballoon in the stomach. Apparently it works, but at least based on the prior abstract, it seems like banding would be a heck of a lot easier. So this abstract looked at angiodysplasia in patients who have aortic stenosis, which goes by the acronym of Hayes syndrome. So it kind of makes sense, but what they did was they did capsule endoscopy before and after patients had trans-aortic valve implantation. What they found is that 75% of patients with aortic stenosis who were going to get the procedure had AVMs, and then they were able to repeat capsule endoscopy on a subset of these patients, 11. So what they showed was after the aortic stenosis resolved, the AVMs decreased in 82%, and in half of them, it went away. And in patients who didn't have resolution of AVMs, if they had multivalvular disease or leakage, that was kind of the risk factor. So it kind of makes sense. So in these patients, rather than trying to go after these AVMs, it might make more sense to have the cardiologist take care of the cause of it, which is the valve problem to begin with. So next set of abstracts has to do with upper GI bleeding prophylaxis. So this is an interesting study, looked at multi-component intervention on GI bleeding risk in patients prescribed warfarin. So it was an interesting study, randomized 220 patients, and physicians taking care of these patients either receive standard notification, which was a form letter, basically with some links to why patients should be on prophylaxis, versus nurse facilitation, which was they received a personalized letter and actually the literature behind why patients should be on prophylaxis. And most importantly, they said, we'll actually prescribe the medication for you and help you make sure the patients take the medication. So with that sort of intervention, they were able to show that discontinuation of antiplatelet agents was higher, and starting PPI rate was actually pretty impressive. 40% of patients got started on PPI versus 0 when they just sent out a form letter. So kind of the take home is if you help the physicians actually start the patients on PPI, it works. This abstract looked at PPI use in prevention of dual antiplatelet therapy associated bleeding. It was a meta-analysis. So there have been actually several meta-analyses already published. And what it showed is that PPI, of course, works, as we know. But the important and the interesting thing was that there was really no difference in cardiovascular events, which was one of the concerns that got a lot of press in the newspapers and stuff. Turned out to be not an issue. So reflux. Raman, I think you presented this abstract already. I've never used a potassium competitive acid blocker, but quite a bit more potent than PPI. Apparently 10 milligram dose of this is equivalent to 60 milligrams of omeprazole, and 20 supposed to be 60 BID, so very potent. And might be an option for patients who have NERD. This is a study that looked at PPI. So there's been recent press about PPI being associated with dementia, memory loss, and all kinds of stuff like that. So COMPASS study was a study that was published in 2017 in New England Journal, and they looked at Xarelto plus aspirin versus aspirin. So the same investigators randomized these patients to pantoprazole or placebo and reported that results in gastro 2 years later. And at that time, they showed basically there's no significant risk to PPI use other than possibly a slight increase in enteric infections. And the relative risk was 1.01. So 1 is not significant, 1.01 theoretically significant, but probably not an issue. And since then, the newspapers, published all this stuff about, oh, it causes memory loss and dementia. Well, it turned out to be there was no difference in cognitive scores or MRI. So again, PPI safe. Upper GI neoplasms. This is an interesting study that looked at global burden of early onset gastric cancers. And I'm sure as you've seen in your practice, it seems like not infrequently we're seeing very young patients coming in with cancers. So in this study, they found that gastric cancer decreased from 1990 to 2019, as we all know. And that was true for early onset and late onset. But the rate of decline was higher in males and males who had higher sociodemographic index compared to females. But more importantly, there was a significant increase in early onset group recently. So when they looked at 2015 to 2019, the annual percentage change was 1.39, and that was significantly increased, kind of reflecting what we're seeing in our practices of young patients coming in with gastric cancers. Why is that the case? This study looked to see if accelerating aging might be a factor in that. So this is a study that used samples from UK Biobank, and they determined biologic age by a pheno-age algorithm. So you can get this like on the internet. You plug in a variety of different numbers like white blood cell, alkaline phosphatase and stuff like that, and you get a pheno-age as a kind of a marker for your biologic age. So what they found was that accelerated aging, meaning your pheno-age was higher than your chronologic age, was associated with early GI tract cancers, in particular stomach cancers, but not so much for late onset cancers. So maybe what we're seeing has to do with accelerated aging. Intriguing thought. So Raman mentioned about Sydney protocol in the esophagus. The other place we use Sydney protocol is for gastric intestinal metaplasia. This is quite common in Southern California, of course, in Asian and Hispanic population. So this is a study from University of Washington. So they looked at 767 patients who had at least 2 endoscopies. So University of Washington group publishes quite actively in this arena. And interestingly, their compliance with Sydney Protocol was only 68%, which I was actually surprised. I thought it'd be quite a bit higher, but kind of matches what Raman said earlier. What they found was that neoplastic progression to 8.6 with extensive IM as a risk factor, and that using Sydney Protocol showed a positive trend towards detection of neoplasia. So Sydney Protocol, I think it's a reasonable thing to do, not only for the esophagus, but for gastric intestinal metaplasia. Next couple of abstracts looked at neuroendocrine tumors, the risk of lymph node metastasis. So current recommendation for neuroendocrine tumor in the duodenum less than 1 centimeter is to take it out with EMR. And we do that most of the time without really thinking too much about it. But they found there's a 10.5% lymph node metastasis, which is pretty high. So if you just take the neuroendocrine tumor out and send the patient on their way and not do any sort of surveillance or workup, you could be missing a significant percentage of patients who have lymph node metastasis. 1 to 2 centimeter range, you could either do EMR or some sort of endoscopic therapy or surgery, pretty high, 25% metastasis, and of course, greater than 2 centimeter, 50% lymph node mets, which is very, very high, which is very surprising. This looked at neuroendocrine tumors in the stomach and the risk of lymph node metastasis. So neuroendocrine tumors in the stomach, 3 types. Type 1 is associated with atrophic gastritis, and what I learned in medical school is that these are really nothing you have to worry about. A lot of times we don't even take them out. Type 2 is MEN, gastronoma. Type 3 is sporadic, and that's supposed to be the one that's scary. But when they looked at lymph node metastasis rates, this is a systemic review, there's a 6% lymph node metastasis rate with neuroendocrine tumors associated with atrophic gastritis, which is actually pretty high and pretty surprising to me and pretty scary because, I don't necessarily even remove all of these in patients who have atrophic gastritis and just recommend surveillance. So esophageal strictures, next couple of slides. This is an interesting study from the Philippines, looked at role of EUS in predicting esophageal stricture formation in caustic injury. So they had 63 patients who came in with caustic ingestions, 60% were due to acidic, and they endoscoped them in 18 hours and did catheter probe. So when they followed them up, 40% had dysphagia after 12 weeks. And what they found is that if there was MP involvement or musculoskeletal involvement on EUS, there was a 100% stricture rate. If there was only mucosal involvement on EUS, then there's 0% stricture rate. 65% was kind of in between with some mucosal involvement. So their suggestion was if there's only mucosal involvement, then maybe patient is home free. This abstract looked at endoscopic incision therapy versus balloon dilation. It was a meta-analysis of 4 studies. So what they found was that incision had higher success rate and lower restenosis. But if you look at the numbers, it's really not that much different, 97 versus 96%. But the complication was more with needle knife compared to balloon dilation. So they had more bleeding, they had more perforation, 3.59 versus 2.29%, and all adverse events rates were higher with needle knife, 6.6% versus 4.4%. So whether that 1% higher success rate is worth having all that complication, I'm not quite sure if incision therapy makes sense, at least according to this meta-analysis. This study looked at migration rate of fully covered stent and kind of makes sense. This is, I think, from West Virginia. They looked at fully covered stent placement, and randomized to either putting a suture or no suture. And as you can imagine, putting a suture took longer, but decreased the migration rate. This looked at endovac therapy. So endovac therapy is vacuum therapy for treatment of large perforations. So this could be done really anywhere, and is adaptation to what the surgeons do to close like a wound in the abdomen in someone who has a very complex wound that can't be closed surgically. So this group looked at Boerhaave's full thickness perforation in the esophagus, and 21 out of 25 had successful resolution with endovac therapy. And of the patients who had secondary therapy, meaning they tried something else, surgery, stenting, or conservative management that failed, they tried endovac afterwards and found that they were able to close the perforation in 6 out of 8. And most of the time, that's how we end up treating these patients, which is something else or multiple modalities fails, and then you try endovac. So this study looked at whether Barrett's esophagus, esophageal cancer risk, is there any eosinophilic esophagitis, and answer is no. Motility, interesting study. As Raman said, you can't really look at go to any meeting without looking at abstracts with artificial intelligence. So this is an interesting study from University of California, San Diego. So they looked at patients who had functional dysphagia. So most of the time when you do manometry is normal in patients who have dysphagia. So 30 to 50%. And these patients, basically everything is normal, and they're called functional dysphagia. So they looked at 4 different types of deep learning methods to analyze what the Chicago classification called normal. So they had 20 patients who had functional dysphagia and 20 patients who didn't have any symptoms. And what the deep learning artificial intelligence showed was that there was actually a pressure difference in the 2 groups, and this deep learning algorithm was able to identify functional dysphagia with about 90% accuracy, suggesting that these patients who have functional dysphagia maybe actually have an abnormal manometry. We're just not picking it up because the Chicago classification is not sensitive enough. That's my last abstract, and thank you very much.